All right, everyone, this is the last antepartum lecture. So the next test is amniocentesis. This is, we're taking a needle, you can see a very large needle, and aspirating amniotic fluid. So it's more precise in detecting abnormal levels of AFP. We do it under an ultrasound, as you can see, because in order to get this needle through this very muscular organ, the uterus, it needs to happen pretty, they have to stab you with it, basically. They have to stab women with this. And I've had it done to me personally. It's horrendous. So they're doing that motion, so they have to make sure that the baby is not in the way and they don't accidentally hit the baby when they're going in with the needle. So you can probably guess that an informed consent has to be signed because there are risks with this. There's risk of uterine bleeding, fetal abnormalities, fetal heart rate problems, all sorts of risks. And I think you're going to look those up for your assignment, what the risks are. You can look up the more risk in the ATI, in your ATI. So we do it about 15 to 20 weeks for the most part. If we're doing it to see fetal lung maturity, we will do it. So if there is a risk for the fetus or mom and we'd like to deliver that baby as soon as possible, we'll do an amniocentesis later on, say 35, 36 weeks, to see if the fetal lungs are mature. How do we check fetal lung maturity? We're looking for the production of surfactant. So if we're looking for genetic disorders or metabolic defects, then we're going to do it around the 15th to 20th week because we're doing it for an entirely different reason, okay? So we're going to have them not hold their breath because it will shift intrauterine contents. We're going to have them have an empty bladder this time in order not to puncture the bladder if they're greater than 20 weeks gestation, of course. We have to have that ultrasound going to see, the maternal and fetal parts. And then we're going to, again, obtain those baseline vital signs for mom and for baby. And then we're going to monitor them very closely during and after for a while after the procedure. The mom will be supine with a wedge under their hip. So remember in this physiological adaptation video from Khan Academy, anytime a woman is lying supine, that gravid uterus is going to cut off the blood supply back to her heart, so through the inferior vena cava. So we want them, if they're ever lying supine, and this is also important with C-sections, the mom has to be supine for a C-section, but we're going to put a wedge under one of her hips to get that gravid uterus off of the inferior vena cava. And then after the procedure, we're going to have her go to her left because that perfuses the baby in the best way because of the circulation. So if we're going to check for fetal lung maturity, this is what we're checking for. We're looking for this lecithin sphingomyelin, or LS ratio. And once the L is 2 to 1 with the S, then we know that adequate surfactant production is occurring, and we call those lungs mature. Meaning, when the baby is born, the requirements for oxygen will be decreased substantially. If there is not an adequate LS ratio and we still need to deliver baby, we do know that we can deliver the baby, and we give them surfactant via an endotracheal tube. So that they do have surfactant to help them decrease their oxygen needs. But we are hoping to have, to let babies still stay in utero until their lungs are mature. So surfactant is made up of lipids, proteins, and glycoproteins, okay? And the ratio of the L to the S is equal until about 32 to 33 weeks. And then it starts increasing lecithin at about that time. And once we get to about that 2 to 1 ratio, then we know there is a sufficient amount of surfactant production. And it usually occurs around 37 weeks. The goal of getting a baby to 37 weeks is one because we know that surfactant production is sufficient. If we have to do it before then, we can. We want to know the status of their surfactant production and the maturity of the lungs. Okay, the last two, there's two more sort of assessments that we take, less common, but there are reasons why we do them. So the chorionic villus sampling, if we know that there is maybe an issue and you know, the parents are seeking maybe an opportunity to abort the fetus that isn't completely normal, we can do this much earlier, and we know that aborting a baby earlier is probably a better idea than later. So it's that first trimester alternative to amniocentesis. We're going to aspirate. You can see this aspirator right here going in, and it's going to aspirate part of the placenta. So there's two different parts to the placenta. There's the chorion, which is the placenta, and the amnion, which is the amniotic sac. So the chorion, you see chorionic villi or chorioamniitis. Those are all referencing to the placenta and amniotic sac. Chorioamniitis. I'm not saying that right. Anyway, it doesn't matter. It's infection of the amniotic fluid. We'll get to that later. But we're going to take a sample of the villus tissue to see if there's any sort of abnormalities at 10 to 13 weeks. So we're going to go through the cervix, and we want that, and we again need to do it under ultrasound to see the placenta, to be able to visualize the uterus and the placenta. And we're going to monitor that fetus to see how well it's doing before and during and after the procedure. And then there are lots of risks, that chorioamnionitis. Oh, I cannot say that today. And that rupture of membranes. ROM is not range of motion in this class. It is rupture of membranes. So any of those things are risks with a chorionic villus sampling. The last test that we do is called percutaneous umbilical blood sampling, and it's exactly what it says it is. We are going to take a syringe and take blood off of the umbilical cord before that baby is born. Do it under ultrasound, same reasons as the other tests, and we can do it for different reasons. Maybe if we need to give a transfusion, twin-to-twin transfusions, there's a possibility of needing a transfusion. You can take a CBC off of it to see how well that baby's doing in utero, especially looking at its acidity. So we can do blood gases, look at the chromosomes, and look for this indirect Coombs. This is to see if there is, in fact, maternal antibodies that are destroying the fetal red blood cells. And then we're going to insert that needle directly into the umbilical vessels, and we're going to monitor them very, very closely to see if there is a hematoma and maybe some clotting going on afterwards, because we do not want that to happen with the umbilical cord. And there's a high risk of bleeding from this procedure. Okay, I think you have your assignments. This is the end of this presentation. I will get this uploaded just as quick as I can, like the others. I'm going to do one more lecture, and then I will be online more regularly as soon as I can get all these done. Okay, hopefully you're all doing well and you're not too overwhelmed with everything. Let me know how I can help.